Hello and welcome to a NANSIG video tutorial. My name is Conor. I'm a medical student at the University of Liverpool, and today I'm going to talk to you about eponymous syndromes. This is part 2 of a two-part series, with part 1 being for cranial eponymous syndromes, and part 2, this part, will be covering spinal and peripheral nervous system eponymous syndromes. You should be able to access part 1, if you haven't already, in the video collections. Hopefully it's uploaded at the same time as this video. Just a quick introduction into the topic again, for those of you that haven't watched the first part. And to summarise, it's just to say that many eponymous syndromes are rare, and as a result they're going to be very unlikely to be encountered by themselves in isolation, but cumulatively they're really not rare at all. And so you're very likely as a medical student or even a doctor to come across at least one of them at some point in your career. They're also very interesting, especially for those with an interest in neuroanatomy and the neurosciences, and that's why we're going to be covering them today. So this is to introduce the spinal and peripheral nervous system. As you can see here, this is just a diagram of the spinal cord. You have the dorsal roots and the dorsal side, which is going to be transmitting sensory neurons from the spinal cord up into the brain for processing. And on the ventral aspect, you can see the motor neurons that are going to innervate each muscle to cause it to contract, relax, or alter in accordance with what the brain is telling it to do. The white matter here is going to be transmitting those fibers, and the grey matter forming the H shape in the spinal cord is going to consist of the cell bodies and the cells that transmit and regulate this process. And the diagram on the left hand side just demonstrates a C6, C7 disc herniation. As you can see here, the spinal cord is nice and uniform. You can see it running down in a nice tubular shape up until this point where it's slightly kinked, and you can see this is as a result of the intervertebral disc protruding and herniating into the spinal cord. We're going to start off with a classic condition. This is called Charcot Marie Tooth disease, or CMT, and what it is a group of inherited peripheral neuropathy disorders. They're also known as the hereditary motor and sensory neuropathies. The prevalence is actually quite common, and it's only present in around 1 in 2,500 patients. But although it is a group of conditions, and although that's what it consists of, it's really known for more classical presentations, with the most classic being this lower limb wasting that you get with this almost like classical champagne bottle leg appearance. There are a multitude of types, and you can see them there and their characteristics, but I don't think learning each individual one is particularly pertinent to your learning as a medical student, unless you're a specialist or particularly interested. What I'd look for is clinically the fact that this condition presents in childhood. Most conditions are autosomal dominant inheritance pattern, and essentially to take from it is that quality of life is good and total incapacity is rare, even if you have this condition. The main classical sign of CMT is in the top right hand corner here, and that is pes cavus, which describes just this concaved shaped foot abnormality that you'll see there, just completely deformed and not quite right. So to summarize CMT, you'd be looking at a presentation in childhood, lower limb wasting with champagne bottle legs inverted, and pes cavus, or a concave foot. To manage it, you just do physiotherapy and exercise to help improve the muscle strengthening. You'd do some occupational therapist input, and you could consider bracing the foot to improve the structure and overall mobility. Moving on to another one, this is Lambert-Eaton myasthenic syndrome, or LEMS as it's more affectionately known. This is kind of similar to myasthenia gravis, and it's almost like a twisted cousin of myasthenia, because myasthenia gravis is classically known to cause weakness that progresses and gets worse upon repeated stimulation, whereas Lambert-Eaton myasthenic syndrome, or LEMS, is the complete opposite, in the sense that upon repeated stimulation after a period of contraction, LEMS actually improves, and it's the weakness that starts right at the start of the movement. It is a very rare disorder in comparison to myasthenia gravis, with an incidence of only 3 to 4 per million worldwide. And the key pathophysiology in Lambert-Eaton myasthenic syndrome is the destruction of presynaptic voltage-gated calcium channels at the neuromuscular junction. And I'll show this in the diagram on the next page. This is in contrast to myasthenia gravis, where the destruction is actually postsynaptic and is at the nicotinic ACH receptors. When you think of LEMS, you should really think of only one thing, and that is the fact that it is often as a result of a paraneoplastic process, most specifically small cell lung cancer, and you should go looking for that if you ever see someone with LEMS. As stated previously, it's all about this proximal weakness, more appropriately the shoulder girdle, that improves with repeated activity, unlike myasthenia gravis. You can get other features like cranial nerve involvement and autonomic involvement like xerostomia, which is dry mouth. That is actually the most common autonomic feature, and you do get this in 80% of cases, and perhaps it's something to remember when you think of LEMS. With regards to nerve conduction studies, you can use these to delineate the exact cause, whether it to differentiate myasthenia gravis and LEMS, and just as described, it will show an increase in amplitude after exercise, and the test may be positive for a tensilon test, which I'll not go into what that is today, but it's never as positive as myasthenia gravis. As stated before, LEMS is all about antibodies against those presynaptic calcium channels. To manage this condition, you would first of all go looking for that suspected malignancy, as previously discussed. However, you can also treat the symptoms with something called 3,4-dipyridamine. This actually works quite well in the sense that it's a potassium channel blocker, which would block channels at your presynaptic nerve terminal, which would actually prolong calcium channel influx, which is deficient in LEMS. So you would end up with more calcium at the end of the nerve terminal, and thus you get an increased action potential and muscular contraction. And there are other treatment options as well that involve immunosuppression. But for now, I'm going to show you, using this diagram, exactly how LEMS presents, what the problem is, and how you treat it. So here we have a normal neuromuscular junction. We can see here we've got the presynaptic nerve terminal, we've got a calcium channel here, and we have a potassium channel here. A stimulus for the muscle to contract, any muscle, would travel along the nerve. It would stimulate, the action potential would stimulate the calcium channels to open, and this calcium influx would cause these ACH, these pre-packed vesicles, to release into the muscle across, and this ACH would react to the receptor, bind to it, and cause muscular contraction, which is great. But in LEMS, this calcium channel is defective, and there's antibodies against it. So with this out of the picture, you get less calcium channels influxing into the nerve terminal, and thus less ACH released, and thus less ACH going to the muscle and causing a contraction. And see how using this 3,4-DAP, it works very cleverly. This would block this calcium channel, this potassium channel. So what you would end up with is the nerve terminal would actually promote a prolonged influx of calcium into the nerve terminal. This prolonged influx, as opposed to an increase in number, it would mean that you would have more calcium in the cell for longer. More calcium would mean slightly, not the normal physiological level, but a slightly increased amount of ACH in this releasing from the cell, from the nerve terminal, and resulting in a bit of an improvement in muscular contraction and hopefully symptoms. The next case is something that most medical students will know, and especially for the neuroscience enthusiasts, a Chiari malformation. This was previously referred to as an Arnold-Chiari malformation, however the nomenclature was changed in order to reflect the role of each individual researcher in discovering it, and I think Arnold's contribution was not as substantial as originally thought compared to Chiari. But nonetheless, it's included here, and it's a congenital abnormality with malformed cerebellar tonsils. That's the key. So you have these cerebellar tonsils. As you can see in here, this is a normal MRI scan. Here's your cerebellum, and here are your cerebellar tonsils. So these are the lower part of the cerebellum that kind of hang down almost like someone's legs hanging off the side of a fence. When they're here, they're fine, and you can see through here. Here's the slit-like fourth ventricle, and here's CSF going to be flowing nice and good all through this brain. However, if these tonsils become, malformed, and they actually protrude further than originally supposed to, just like this one here, you can see these cerebellar tonsils are protruding, and they're actually, you can see that there's good flow of CSF in this MRI, but in this one, it looks as though that's completely blocked. And you see, and of course, this would lead to a blockage in CSF production, and you would get infantile hydrocephalus, optic atrophy, and sometimes a spastic paresis of the limbs as a result of this. There are two main types of Chiari malformation. There are other types, but I think type 1 and 2 are the most important. Type 1 is relating to the cerebellar tonsil specifically, dissenting through the foramen magnum, and type 2 actually represents a larger abnormality. This would be of the cerebellar vermis that would herniate through the fourth ventricle and not the tonsils. The Chiari type 2 is also associated with other neural tube defects, most commonly a meningocele or myelomeningocele, and you can also get hydrocephalus with it. With regards to clinical features, this condition often presents in childhood with the resulting hydrocephalus that we've described, and a condition called syringomyelia, which is it's essentially the development of a cystic cleft or syrinx in the central canal within the spinal cord. This could be filled with fluid or filled with other things. And it also, in adults more commonly, or in adolescence towards approaching adulthood, it presents with suboccipital neck pain in most patients. And this is often more likely to going to be a Chiari type 1 as opposed to a type 2 if it presents in adolescence or in adulthood. You can get other symptoms, but they're less common. The prime investigation, as we've just shown in the previous slide, is an MRI to localize and diagnose it. And with treatment, the main treatment is surgical, and this would be a posterior fossa decompression operation. So what you would do here is you would surgically open up the back of the neck to access the tonsils, and then decompress the CSF blockage. And you can use things like a duroplasty, which would be using a bony plate to actually seal off the decompression, and you can also use a laminectomy as well. The next syndrome we're going to discuss is Guillain-Barré syndrome. I'm hoping that most clinical med students will be familiar with this one. It has a myriad of names, such as the one listed in the title, but we're just going to keep it to GPS for short. This is almost always caused by a reaction to previous infection with Campylobacter, and it's actually reported in 1 in 1,000 cases of someone having Campylobacter. To summarize it, it's known as ascending areflexic paralysis, and this is because you get a unique phenomenon called molecular mimicry, where the body attacks and mistakes our own cells, namely our myelin, our oligosaccharides involving our spinal cord. Our body mistakes them for some of the antigens that would be represented on the Campylobacter that we've been previously infected by. And thus you would get gradual antibodies against this, leading to demyelination of most commonly peripheral nerves. This would tend to cause an acute paralysis that would start slowly but evolve over days or weeks and cause an ascending areflexic paralysis. The symptoms can include paresthesia, weakness, and overall paralysis. With it affecting peripheral nerves, these aren't too much of a problem, but the key problem arises from the fact that it can also affect the muscles that supply your respiratory system, and up to 20% of patients, although it may be less now, I believe it's around 10%, actually require ventilator support for this. With regards to investigations, you don't usually need them, and you can make a clinical diagnosis based on respiratory involvement, based on previous Campylobacter symptoms, and based on previous known infection. But you can do an LP which shows an increased CSF protein, and you may conduct some nerve conduction studies in ambiguous cases, which would show some demyelination, but it's generally clinical. What you're going to do with this is substitute the patient's immunoglobulins for ones that aren't directed against their own peripheral nervous system, and you're hoping to get rid of those ganglioside antibodies by using IVIG and the plasma exchange. And some debate, there is a role for the use of steroids, and some clinicians recommend it and some don't, and that's usually based on their previous experience. The prognosis for Guillain-Barré syndrome is usually quite good, and 85% of patients do make a complete recovery or near complete. Mortality still is high, and it is 10%, and this is mainly due to those respiratory complications like respiratory failure, as we previously discussed, and most patients won't end up with a disability if treated properly. The next syndrome is once again more classically known to med students, given the fact that it's taught very heavily in medical school curriculums. This is the Brown-Séquard syndrome. Well, Brown-Séquard syndrome is a lesion of one half of the spinal cord, so this is a hemichord lesion, and this is going to affect only one side of the spinal cord. A classical cause for this could be something like a bullet that would only go through one half of the spinal cord, a stab wound specifically in one side of the back, a disc herniation, or transverse myelitis, even though this is less common. And Brown-Séquard syndrome, while it sounds there would be some complex symptoms, it's really quite simple. As a med student, all you need to remember is that one leg is weak and one leg is going to be numb as a result of this. And this is because the hemichord lesion would cause ipsilateral, so the same side. So say if we have a lesion, a Brown-Séquard lesion on the right hand side, you get loss of proprioception and vibration on the right side. This is because the innervation of the proprioception and vibration, also known as the dorsal column system, these fibers would not cross over or decussate, yet they would get hit by this lesion and they would not be able to work. Because they cross over at the pyramids in the medulla in the head. So by the time that they were to come up, they will get hit by this lesion and not function. In contrast, you get contralateral, so the opposite side, loss of pain and temperature. And this is because the tract that supplies your pain and temperature sensation, also known as your spinothalamic tract, actually decussates immediately in the spinal cord upon entering. So say if you had one on this left leg here, and a spinothalamic fiber, it would enter the spinal cord at the right hand side, and then it would cross it would enter the spinal cord at the left hand side, and then cross over to the right, and then ascend up, and then get hit by this lesion again, and not be able to transmit that sensation. So without having to remember it and having to understand the pathophysiology, I think it is important, but I think knowing that there's one leg weak and one leg numb is going to get you just as far as understanding it will. And I should also point out that the one leg weak, the loss of leg power in the same leg as the loss of proprioception and vibration, comes from that same fact that the corticospinal tract, which is involved in all voluntary muscle movements, starts in the brain and then decussates or crosses over at the medulla, just like the dorsal columns, and thus is going to get hit on its ipsilateral side. There's two other conditions to finish off this video. The first one is Friedreich's ataxia. This is a trinucleotide repeat disorder, so in essence it's just like Huntington's in the sense that it exhibits anticipation. It is inherited and it's an autosomal recessive disorder. The pathology is to do with mitochondria production and the defective production of a protein called frataxin. Now this protein is present in mitochondria and regulates ion transport and storage. If you don't have this protein, you're going to get dysfunction of these high energy cells and death of the mitochondria. Specifically, Friedreich's ataxia manifests as cerebellar problems, which is hence why it's called Friedreich's ataxia, and you're also going to get dysarthria, weakness, and you may also get dysdiadochokinesia with it as well. The onset is usually before age 25, and there's a few features to find on examination, as listed below. And there is a progressive loss of knee and ankle reflexes, progressive weakness, along with the cerebellar symptoms, and most will become wheelchair bound by age 25 as a result of the weakness and the degeneration of those nerve tracts. The two big complications with Friedreich's that you need to be aware of, and one is diabetes that happens in 25%, and HOCM, which happens in 50%, which is hypertrophic cardiomyopathy. And this proves to be the cause of death for most patients with Friedreich's ataxia, and it occurs in the 6th decade, and it's important to monitor this when you follow it up. The final syndrome in this video is Devic syndrome. This is similar to some syndromes I've discussed in part 1. It's not used as much, the phrase Devic syndrome. It has been phased out a little bit in favour of the newer name, which is Neuromyelitis optica, but I think it's still used by clinicians today, and so it's important to know what it means and that it is the same thing. This is a inflammatory demyelination that is very, very similar to MS, but it's not MS. You get inflammatory demyelination, just like MS, except that you get attacks of optic neuritis and myelitis. However, when you do a brain MRI, you don't fulfill the requirements for MS. So you may get similar symptoms like optic neuritis, transverse myelitis, so symptoms of paresthesia, urinary problems, and other problems that you might think are disseminated in time, space, and person, just like MS. However, when you do your brain MRI, you don't find the plaques that you're looking for to diagnose MS. At this point, you would consider some more investigations, and this is where the pathophysiology of the condition comes into play. When you do an LP and you look at the CSF, you're not looking for the oligoclonal bands that you might see in MS, but you're looking for something very specific, which would be antibodies against something called AQP4, which is an aquaporin 4. So aquaporin 4 antibodies would be positive if you're looking at neuromyelitis optica and not MS. But far and away, the much more common differential for this condition is MS, and this could be used, for instance, in finals when you have a barn door classical MS case and you need to give one of the differential. Giving this other differential is going to make you look really smart, and if you can list 2 or 3 things from this, it's going to be really, you're going to really impress those examiners. Treatment is similar to MS, and it mainly consists of dampening down the immune system with steroids and the inflammatory system with things like plasma exchange and immunomodulatory drugs like azathioprine and rituximab. And so that concludes the video today. Thank you very much for listening. I'm available via this email address, as you can see here. Feel free to contact me if you have any questions, any queries or concerns, and I'm happy to discuss it with you. And I'd just like to give a massive thank you to Dr. Rhys Davies, who's a consultant neurologist at the Walton Centre, for his review and approval of this article, and I'm very grateful for his input as well in assuring the quality of the content. And I'd also like to give a special thanks to Stephen Doherty for his continued support and help with the artwork and design of the presentation. With regards to references, I use the combination of the Oxford Handbook of Clinical Medicine, the chapter on eponymous syndromes, BMJ Best Practice, and Eureka Neurology and Neurosurgery. And big thanks to Nansig for letting me do this tutorial for them. Thank you very much.